Hello, today I'll be presenting a case of a patient with catastrophic antiphospholipid syndrome, or CAPS. So first, what exactly is CAPS? CAPS is a complication or a severe manifestation of antiphospholipid syndrome, which is a condition in which patients present with a hypercoagulable state due to autoantibodies against phospholipid binding proteins. And as I said, CAPS is characterized by widespread severe thromboses throughout the body that can involve multiple different organ systems. And if we look at figure 1, we can see just how many of the organ systems in the body can be affected by these thromboses that occur. CAPS usually is caused by some sort of triggering event, which could include infection, surgery, malignancy, amongst other things. Just like antiphospholipid syndrome, CAPS occurs predominantly in a younger female population, and it does have quite a high mortality rate at about 40%. Now, for our case, we have a 69-year-old male who had a pre-existing diagnosis of antiphospholipid syndrome, as well as factor V Leiden deficiency, multiple prior venous thrombosis events, and AFib, who presented to the hospital with altered mental status following a prostate biopsy. In terms of his physical exam, he was tachycardic, febrile. His neurological exam was mostly normal, although he was nonverbal and unable to follow commands. And his skin exam showed large rashes with bulla and erythema, these violaceous patches, like we can see in figure 2, on his right leg, abdomen, and his flanks. In terms of his labs, he had a low white count, low normal platelets, and an elevated prothrombin time. Ultimately, he was diagnosed with a left frontal subdural hematoma following a CT scan. In terms of his hospital course, he had a skin biopsy done on his first day in the hospital that showed a thrombotic vasculopathy, which was consistent with his existing diagnosis of antiphospholipid syndrome. Later on, hospital days 2 to 4, his platelet count dropped quite low. And then later in hospital days 8 and 10, we found extensive thromboses throughout his left leg in various veins, including the femoral, popliteal, and posterior tibialis veins. And as we can see in figure 2, they were accompanied by these large violaceous rashes with bullae that were weeping that caused concern for phlegmatia ceruleum dolens. He also developed an AKI at this time with his BUN and creatinine increasing significantly. So to treat this, we treated the patient with platelet transfusions, steroids, rituximab, and IVIG. Ultimately, his platelet count came back up. We were able to restart anticoagulation, and he had significant improvement in his clinical condition and was later discharged. So how did we decide that this patient has CAPS? Well, CAPS has a criteria that involves 4 elements, which include A, involvement of 3 or more organs, systems, or tissues, B, development simultaneously or across 1 week, C, histopathological confirmation of small vessel occlusion, as we saw with our patient's skin biopsy on day 1, and D, the laboratory confirmation of antiphospholipid syndrome, which our patient already had. So definitive CAPS requires all 4 of these, but you can also diagnose a patient with probable CAPS using various combinations of the criteria, as we can see here. Our patient, ultimately, we diagnosed with probable CAPS due to him partially meeting criteria A with the skin and venous systems involved, and fully meeting criteria B, C, and D. So why does all of this matter? Well, this case of CAPS occurring in a 69-year-old male as opposed to a young female who is not fully meeting the diagnostic criteria shows that these criteria are not necessarily a diagnostic tool, but rather work to classify the condition so we can understand exactly what's going on. I think from this case, what we can take away is if a strong clinical suspicion exists that a patient has CAPS, even if they're not necessarily meeting these classification criteria fully, treatment should go ahead and be started to avoid poor outcomes, because in this patient, we didn't necessarily have a strong diagnosis of CAPS, but we were able to treat him and get a huge improvement in his clinical condition and ultimately send him home. Thank you.